both for all the written work he's done and also for the number of institutions he's led, both internationally and nationally. And I think many of us have benefited from his wisdom in both his writing and his talks over the years. Professor Graham is Emeritus Professor of Child Psychiatry at the Institute of Child Health, and what may be of interest to many of you here today is actually a former president of this organisation. And I'm very delighted to welcome him today.
Thank you.
We have to call these slides one by another to the application because you're experiencing some problems.
So, next slide is this?
Yeah.
Up here?
No, you have to call it.
Oh, sorry, I have to call it. Next slide. So, first slide, please. Thanks. Dr. Wolpert, ladies and gentlemen, is it possible to have just a little light on the audience? Oh, that's great. That's fine. I don't want to see them too clearly. Just to know how many are asleep. That's all. Can you hear me at the back there if I talk like this? Yes, and if I talk too fast, and I will try not to, I don't usually talk too fast because my thoughts don't come very quickly, and so my mouth usually goes at the slow speed that my thoughts allow it to. First, may I say it's a great pleasure and honour for me to be asked to deliver this talk in Florence, the leading city of the Renaissance, the place where there was this birth or rebirth of humanism, where faith in the human mind and spirit to solve problems was first articulated. And it seems very appropriate that our conference, which aims to encourage the human mind and spirit to solve problems, should be held here. I just want to add a little bit, for reasons that I'll explain in a moment. I'd just like to add a little bit to the introduction that Miranda provided for me. I entered psychiatry in 1961, that is 46 years ago, worked with Michael Rutter on the Isle of Wight study in the 1960s, the mid-1960s, and then, of course, was trained in clinical work and moved to the place where I spent most of my time at Great Ormond Street and the Institute of Child Health in 1968. From which I retired some years ago, and since then I've done no clinical work. But I suppose I stored up. I saw about 100 new cases a year, and that means that over 25 years, and it was rather longer than 25 years, I saw 2,500 new cases. New children, new families, and they were very varied. So I have a sort of store of information about those cases that continues to fuel the ideas that I have in child and adolescent psychiatry. The academic department in which I worked was strong in epidemiology, but also we carried out 7 controlled clinical trials and were therefore very interested in the evaluation of therapy. After I retired, I've been involved in writing, reading, organising meetings and taking part in meetings, and not long after I retired, I realised I organised a number of meetings for the Royal Society of Medicine in psychiatry, and the attendance was always very poor. Sort of 20 or 30 people would come along. And then I organised a meeting on cognitive behaviour therapy for children and families, and something like 150 people came to this meeting. And I said, why have you all come to this meeting? And they said, well, there's nothing to read on this subject. So I thought, well, there's an opening here. So I edited a book on cognitive behaviour therapy for child and adolescent, for children and families, and that is now in its second edition. So although I have a much more academic than practical experience in cognitive behaviour therapy, I feel I do know something about the literature because of having to read all the chapters that came in this edited book. Now, next slide, please. This talk is divided into three parts, as the title suggests. I'm going to talk a bit about the past, rather more about the present situation, and then I'm going to take a look into the future of cognitive behaviour therapy. I'm a little worried about the level of this talk, so I just want to ask you, first of all, how many of you actually have used cognitive behaviour therapy? Could you put your hands up in your clinical work? So, a lot, but not everybody. How many have not used cognitive behaviour therapy in their clinical work? A relatively small number. Encouraging. How many of you have been trained in cognitive behaviour therapy? Pretty large. How many of you have not been trained in cognitive behaviour therapy but use it? Well, about a third of those who, that is interesting, about a third of those who are using it have not been trained in its use. Don't feel bad about that. I was really not trained in anything and continue to use pretty well everything, so you shouldn't worry about not having been trained. How many of you have used some form of psychodynamic psychotherapy? So, how many of you have not used a form of psychodynamic? Virtually nobody. How many of you, but quite a lot of you, said you hadn't actually used it, but not many. I suppose about 2/3 of you have used psychodynamic psychotherapy, slightly about the same as cognitive behaviour therapy. How many of you have been trained in psychodynamic psychotherapy? So a lot of you. How many of you have not been trained in psychodynamic psychotherapy? A few. Well, that poses a problem because obviously you have different levels of knowledge and sophistication in the subject on which I'm going to talk. I shall try and provide something for everybody, but some of what I say is going to be obvious and really well known to some of you, and some of it might be a bit unfamiliar and difficult to absorb for others of you. So people talk about a bird's eye view of a subject, at least we talk about a bird's eye view. Some of this is going to be what I would call a spaceship view, and some of it will be a worm's eye view from the point of view of the practitioner engaged in everyday practice. Could I have the next slide, please? First, a bit of history. You will know that these were the figures who really dominated the first 3/4, I suppose, of the 20th century in terms of the psychological understanding underlying the delivery of psychological methods of treatment. Adolf Meyer, who I think was Swiss originally, but worked in the States for most of his career. John Watson, who was very definitely American, and Sigmund Freud, who was Austrian and lived in Austria apart from the last few months of his life when he came to England. And these were the figures whose writings really influenced what people did in the first 3/4 of the 20th century, and their influence is still in the 21st, well into the 21st century, I think, very much alive and well, all of them. One frequently hears people, if you ask people what their orientation is, they may hesitate and then say, well, biopsychosocial, or they may say very firmly that they have a psychoanalytic or psychodynamic orientation, and much less commonly they will say they have a behavioural orientation. Could I have the next slide, please? When I entered child psychiatry in the very early 1960s, the therapeutic approaches delivered in virtually all the clinics, certainly in the south of England where most child psychiatry was placed, was almost entirely psychoanalytic. Sometimes wasn't immediately obvious that this was the case, but when you read an advertisement saying this clinic is dynamically orientated, you knew that if you weren't in analysis or if you hadn't had a psychoanalysis, you had absolutely no chance of being appointed. And that was the case with most of the clinics in the United Kingdom at that time. And that had been the case from the beginnings of child and adolescent psychiatry and the child guidance clinic movement from the late 1920s, early 1930s, up to the time that I entered child psychiatry. Next slide, please. Now, again, round about the time that I entered child psychiatry in the early 1960s, behavioural psychotherapy had a very small place, but virtually no place in most clinics, but at specialised centres like the Maudsley, it had a small place. Therapeutic approaches derived ultimately from Pavlov and Skinner had been modified, particularly by Hans Eysenck, originally German, but for most of his career practicing in London, by Joe Wolpe, who came from South Africa to London and then to the States, and by Jack Rackman, also from South Africa, who then went to Canada. And all of them were violently critical of psychoanalytic procedures and pointed to the lack of evidence that psychodynamic techniques were of any use in changing behaviour. However, they in fact managed to develop techniques that only had a very small applicability to child psychiatric problems as seen in clinics. I did a small pilot study in 1963 and 1964, a pilot study, a controlled clinical trial of a number of cases, selecting my cases from those that seemed to me where there was some evidence that behavioural approaches might be effective. And there were only, of the Maudsley case material at that time, only 5 to 7% appeared appropriate on the basis of what had been published at that time. And they were largely in these three conditions that I've mentioned here. Next slide, please. Now, over the next 25 years, there was a decline in the use of psychoanalytic procedures, though there remained a number of centres in the United Kingdom, particularly the Tavistock and the Anna Freud Clinic, which I would recall as having, or describe as being sort of unrepentantly psychoanalytic. Despite all that was going on around them, they remain centres of excellence in psychoanalysis, and indeed have largely remained so, though there have been tremendous developments in psychoanalysis in both those clinics and changes in orientation since that time. But what happened over this period, from 60 to 75 particularly, was a lively interest in family systems, structural family therapy, large numbers of schools named after different people, like Minuchin, or named after different cities, like Milan, that were identified with particular approaches in family therapy. They continued to be largely unevaluated. There was a terrific creative energy at that time, and the department in which I worked was certainly tremendously excited about what they regarded as really innovative, creative, and they were innovative and creative, but again the amount of assessment and systematic evaluation was very small. Next slide, please. Now, before I entered child psychiatry, but not much before, there had been a revolution in academic psychology, that is, in the sort of psychology that was practiced in undergraduate, that was taught in undergraduate departments, and in which postgraduate psychologists, academic psychologists, carried out their work. I was an undergraduate. I did part of my degree at Cambridge was in psychology. I did part of my so-called tripos was a year's psychology, and it was almost always what I would call almost all rat psychology. We learned about how rats went up mazes and what could make them run up to one side rather than the other. It was incredibly boring, and if ever any, there were various points at which I might have been turned off psychology and psychiatry, and that was certainly one. And in the early I suppose I did this course in 1955. I realise I'm rather giving away my age at this point, and that's a slight worry for me. The day before yesterday, Dr. Sikorsky mentioned the fact that his wife was was involved in business and finance, and this had led him to take an interest in cost analysis and so on. Well, I better confess that my wife is a psychiatrist for the elderly, and the really good thing about being married to a psychiatrist for the elderly is that you get more interesting to her as you get old. But she let me come along this morning, so clearly I sort of passed her mini-mental or whatever it is. Now, as I said, cognitive psychology transformed academic psychology and has remained a powerful theory and paradigm. And these, just as I'm talking about the past for a little bit, these are the people who played such an important part. I should really have put Jean Piaget, Swiss, at the top of this list, but I forgot, because Jean Piaget was really, in terms of developmental psychology, he introduced cognitive psychology to the field. But in terms of the sorts of the people who made an impact on academic psychology, certainly in the UK, Alan Turing. Here we've got one Englishman and three Americans. Alan Turing, who was the father, really, of computing. Who, if one named one person who was responsible for the development of computing, it would be Alan Turing. Just one sort of little interesting fact about him that you may not know is that this incredibly gifted man was gay, homosexual, and we had laws in our country that meant that homosexual behaviour was criminal. And I can't remember exactly the date, but in the early 1950s he was arrested attempting to make contact with a man in a public lavatory, and the man, of course, turned out to be a policeman who was an agent provocateur, and he was up before the court, was remanded for a week, and then would have had to go back to court. But he committed suicide. He committed suicide. This is a story that I've seen written down. People doubt it, but I believe it to be true. He committed suicide by putting some cyanide on an apple, and he ate the apple. And I understand, though this may not be the case, that is why Apple computers are called Apple computers. It's in memory of Alan Turing. It took another 10 years before the UK laws were changed. Anyway, then there are these Americans, Claude Shannon, involved in the development of information theory, Norbert Wiener, the father of cybernetics, and Noam Chomsky, who, as you will know, fathered psycholinguistics, is still alive, though he's now much better known for his ferocious attacks on his own government in relation to their foreign policy. Next slide. And I suppose they must have been inspired by the developments in academic cognitive psychology, but not all that obviously. These two figures then emerged. Albert Ellis, who died about a month ago at the age of 93 or 94, developed rational emotive behaviour therapy, an extraordinary a psychologist, trained as a psychoanalyst, but never, I suspect, a very conventional psychoanalyst. The story came out in his obituaries, that at the age of 19 he was very worried about his shyness. And he went to Brooklyn Central Park and sat on a bench and tried to make approaches to 130 women who passed him by. And he had 130 rejections. But he said, nobody hit me, and nobody called the police, and I realised I could cope with rejection. He was that sort. It sounds, I never met him, it sounds as though he was the most extraordinary individual, and his idea was you faced up to your problems and you did something in real life about them. And there's still an institute of rational emotive behaviour therapy, I believe, in New York. And Aaron Beck, who's still alive, was, I suppose, the father of originally cognitive therapy and then cognitive behaviour therapy, continues, or until very recently, has been writing very actively. And both these men were trained in psychoanalysis. Next slide, please. Now, gradually, and very gradually, their work on cognitive behaviour therapy percolated into the children's field. But it was very slow. And indeed, in 1984, from 1984 to 1985, if you look up Medline, you find 3 papers dealing with adolescents and cognitive behaviour therapy, and 1 relating to children, whereas the last couple of years it's been 24 papers relating to adults and 10 relating to children. So there's clearly been a very considerable growth, and there were hardly any between 1984-85 until the mid-1990s or even later. There were hardly any papers on children. It was Philip Kendall's book, published in the States, on cognitive behaviour therapy in children, that really made a mark, and my own followed a bit later. And clearly, from the numbers of copies that have been sold, there is a demand for information on this subject. Next slide, please. Now, many of you will know this, but I just want to put up this very clear statement that Aaron Beck formulated early on in his central... Well, I won't read it out. You can read it. I'll give you a moment to read it. This is what cognitive behaviour therapy is all about. I'll just let you read, I think, the next 3 slides. Could I have the next one, please? I'm just going to put up a little information about schemas, because it seems to me these are the central, the sort of core aspects of the theory. That schemas, notional mental structures, they don't exist in any concrete way, even neurophysiologically, but there are networks that reflect clusters of ideas that are based on our early experience, that may be plastic, easily modifiable or rigid, and that really makes a difference. Next slide, please. And if new information comes in that is discrepant, the schemas may be modified to take account of the new information, or alternatively the information may undergo a process of distortion. But the schema may then be maladaptive. Next slide. There are obvious similarities to psychoanalytic concepts such as repression here, and previous versions of this talk I've dealt in some length at the differences and similarities with psychoanalysis and behaviour therapy, with cognitive behaviour therapy, but I don't have time to do that now. But clearly there are differences. Next slide, please. Now, in practice, the general principles of cognitive behaviour therapy, as those of you who have practices, and that is most of you, will know, involve first a period of engagement, and I want to come back to engagement because it is perhaps the most important aspect of any form of therapeutic intervention, whether it be medication or psychological form of intervention. The whole process of engagement with the child or adolescent, the young person, and the family, and the way that is carried out is terribly important. Whether you regard motivational interviewing as a necessary preliminary to treatment or as one aspect of cognitive behaviour therapy is neither here nor there. But we all need to know the principles of motivational interviewing. They are it's a very important concept that has come out in the last few years. And then those who practice cognitive behaviour therapy do, I believe, hope and believe at any rate, carry out a full assessment, which need not be enormously time-consuming, but which must be much wider than looking at what is relevant to the use of cognitive behaviour therapy. I think that people who are very specialised risk missing important types of information. I worked with colleagues who worked in child sexual abuse, for example, and it's very easy if you're focused entirely on sexual abuse or on anorexia nervosa or on any of those subjects in which people do become very specialised, to miss out very important aspects of the history, either of the family history or of the child's history. A number of cases of obvious ADHD that have been missed because people have been interested in other things. An assessment does need to be... and then if one is embarking on cognitive behaviour therapy, the importance of psychoeducation, applying specific psychoeducation, that is informing the patient and the family, the client and the family, about the nature of cognitive behaviour therapy, finding out what they know about it already before you do that, because it's pointless to tell people things they already know. And these days, with the internet particularly, people often know things before you tell them, and it's embarrassing to be told after 3 or 4 minutes that yes, they know all that and you've wasted that time. I think these days particularly one needs to find out what people know before you embark on telling them. And then the application of the specific techniques and monitoring and evaluation. Next, please. Next slide, please. Now, I'm not sure, I want to spend a little time, but a very little time, going through CBT approaches to 3 different types of disorder: anxiety disorders, depressive disorders, and obsessive-compulsive disorders. But these are things you can read about, and I'm just going to leave these up for a moment so that you can absorb the information on them, that they'll be familiar to you. 1 or 2 of the things that I'm going to say in relation to each of these disorders may be less familiar to you, but certainly you will, I think, be able to identify with what's written here about the way in which cognitive behaviour therapists apply the theory they have to anxiety disorders. Next slide, please. And then there are CBT techniques for anxiety disorders, again very well described in the literature, and I think pretty well summarised here, at least I hope so. And all of this will be, I think, familiar to you. But then, and this might be slightly less familiar, I hope so, to some of you. Next slide, please. There is the evidence for the effectiveness of CBT in anxiety disorders, and there is really only one good meta-analysis that carried out by Sam Cartwright-Hatton, published about 3 years ago, and that the summary of her finding is that the remission rate of anxiety disorders was 57% compared to 35% in control groups. Now you may think, well, that's quite a big difference, and it is certainly a statistically significant difference. How you evaluate that is highly problematic, and will be much of what I'm going to say will, I think, be discussed in more detail, and I think probably in more critical detail by Peter Fonagy in the next talk. But how one evaluates evidence, it's become apparent over the last 7 or 8 years, I suppose, is deeply problematic. These trials were, in fact, trials carried out without a placebo control group. They were carried out with people who got no treatment. Now we know that placebo is a powerful effect. So once you know that, a difference of 22% becomes immediately a great deal less impressive. Next slide, please. Now again, I'm not going to spend time. I think those of you who practice cognitive behavior therapy will know about negative automatic thoughts as the primary experience of depression. The patient who is depressed, the 14-year-old, sees somebody across the road who doesn't appear to, an acquaintance who doesn't appear to acknowledge them, and they know straight away that is because they didn't want to meet them, they didn't want to see them. There's something that they've done, the depressed person has done, that makes them not worthy of attention. It's something that happens automatically. And the depressed mood is secondary to that experience. People who are not depressed, and I've sort of carried out this exercise with a number of people, they tend to say, so what would you think? Well, I think maybe she'd not brought her glasses that morning, or maybe she was thinking about something else. I better give her a ring when I get home and make sure she's all right. That's not what depressed people think, and that is it's a very powerful difference between people who are significantly depressed and people who are not. So experiences are distorted to fit these assumptions. And then, next slide, please. The techniques are similar but not identical when faced with a depressed child or adolescent. One first establishes an alliance with the child and the family, and then goes through this procedure of psychoeducation and then the application of specific techniques. Next slide, please. But again, what may be less familiar perhaps to some of you is the fact that there has been one very comprehensive study demonstrating that with a large number of teenagers aged 12 to 17 years with mild to moderate depression, and this was a placebo-controlled group with and without fluoxetine, probably the most effective antidepressant for adolescent depressive disorders. The combination of CBT plus fluoxetine was a bit superior to monotherapy, and indeed the suicidality was slightly higher in the group that didn't have the cognitive behavior therapy but only the fluoxetine. But as Ian Goodyear, and I didn't hear it, but I would be surprised if Ian Goodyear's talk yesterday didn't include his recent study published in the British Medical Journal 2 or 3 months ago, perhaps a bit less, showing that CBT is ineffective in severe cases of depression when he suggests antidepressants are needed. Next slide, please. Now again, I'm going to go fairly rapidly through obsessive-compulsive disorder, and Paul Salkovskis, whose name I've put at the bottom here, is perhaps responsible for the clearest formulation of cognitive approaches to obsessive-compulsive disorder, that enhanced sense of personal responsibility that produces a distortion of arising probably from both genetic vulnerability and from upbringing, results in a distortion of information processing. If I don't wash my hands for half an hour, my mother will die or my mother will fall ill. And these recurrent intrusive thoughts are interpreted as causing harm to the self and or others. Next slide, please. I won't spend any... You will know that there are well-established techniques involving particularly exposure and response prevention to obsessive-compulsive disorder, and it is clear that the concomitant use of medication improves the likelihood of sustained outcome because, next slide please, you will see that there is... Next slide please. The one significant study multi-center study of pediatric obsessive-compulsive disorder shows that there is a very marked difference between those who have been treated according to the CBT protocol with a combined remission rate of 54%, placebo only 4%. This is a chronic condition, with improvement maintained for 18 months. Now, that is very impressive. And I have to say that if I were, or if a colleague were asked to give evidence in a child who'd been treated for obsessive-compulsive disorder unsuccessfully, and this approach had not been used, and the parents decided to take legal action, it would be quite difficult to defend somebody not using this approach. So this is, on this evidence, this is a really important and significant difference. But I'm sure that looking at the work more carefully, one could pick holes in it. Next slide, please. Now, these are the conditions. I can recommend this booklet produced by Miranda Walpert, who's chairing this session, Choosing What's Best for You, and there are going to be quite a lot of copies available. This is a booklet produced for parents and young people. It's called Choosing What's Best for You, What Scientists Have Found Helps Children and Young People Who Are Sad, Worried or Troubled. The first edition is July 2007, so it's very up to date. And that summarises the information that I'm going to provide in the next 2 or 3 slides. So these are the conditions where there is at least one controlled trial, sometimes blinded, sometimes not, in which there appears to be a significant difference between those treated and those untreated. And then, next slide please, this will be up on the net, so I think the PowerPoints are going to be available on the internet. These are the conditions where there is no very satisfactory controlled clinical trial, but there is evidence that CBT has produced promising results. And then these, next slide please, are the conditions in which one would have to say that there are other treatments that have been tried that are more successful than CBT, and where one would be unwise to use CBT as a first port of call. Next slide, please. Well, what about the future? Let me catch myself up in terms of my notes. I'm going to... obviously there are certain things about the future that go without saying. There needs to be more basic cognitive research, there needs to be more neuroscience, imaging and so on in relation to these various conditions, relating intervention to changes in neuroimaging findings. There needs to be more evaluative studies. There needs to be looking at efficacy and effectiveness, as well as cost benefit. That is ça va sans dire, so to speak. Those are all the things that one would have to, as an academic interested in the future, those are all the things that one would have to say, and they're all very important. But I don't want to say them because everybody would say those things. I want to say a few things that are perhaps a bit less obvious but seem important to me. I'm going to talk about a number of concerns. I'm going to issue a number of warnings, and I'm going to point to a number of dilemmas. Next slide, please. The first reason for concern is that quite clearly cognitive behaviour, the theory underlying cognitive behaviour therapy is flawed in various respects. You only have to think about your own personal experience to realise that thoughts are not, when you have depressive feelings, and we all have depressive feelings, that there's something really wrong with you if you don't, we all have depressive feelings, and they're not always preceded by depressive thoughts. You can have a viral infection, you take steroids, various physical conditions, rapidly produce changes in your mood without any intervening thought processes. So it just isn't true to say that depressive feelings are always preceded by depressive thoughts. There is a cycle. And it's important that those treating depressive disorders recognise that. So that's one major reason that the theories are either poorly worked out, or as in the case of some conditions, or are actually pretty obviously flawed, as everyday experience will confirm. Next slide, please. Then there is a risk of the claims for CBT being overstated. There was Sandra Mendlowitz who gave a talk yesterday, as I heard, that was really excellent about the use of CBT in mutism. Her paper was called When Cognitive Behaviour Therapy is Not Enough. Well, let me tell you, cognitive behaviour therapy is never enough. Okay, there always needs to be other things that you need to do other than the delivery of the specific techniques associated with cognitive behaviour therapy. And that will, I think, be fairly obvious to anybody who has practiced it, as so many of you have. Next slide, please. And I think a third reason for concern is really overemphasis on the techniques that are used. There is increasing evidence from the adult literature, though I don't think this exists in the child literature, that the techniques that are used are much less important than what goes on before and around and in the relationship and the nature of the approach of the treatment, in the sense of the need to transform the meaning of the presenting problems to the child and for the child and family. I've referred elsewhere to the importance of engagement, and I can't put too much emphasis on this, and I shall come back to it. But what those studying the results of evaluation in the adult literature now point to is the fact that there is very often outcome equivalence, that is, people finish up the same, with content non-equivalence, that is, when what is delivered to them is different. And I think we have to pay attention to that. Now, I'm not saying that what you deliver doesn't matter in terms of content. I think it does matter, but I think you have to be rather careful when you over-ascribe power to what you actually do. We all have a sense of omnipotence in what we do, and I don't accept myself from this. Let me tell you one instructive story that I've told some time before. In a time when I did some, I suppose one would have to call it play therapy, with an underlying psychodynamic approach, I had a boy referred who was very, very angry, and it wasn't quite clear what about. But it became clear to me over the first few sessions that he was extremely jealous of his younger brother, who was brighter than he was and better looking. And then in play, he actually revealed in play between two animals his aggressive and destructive feelings with one a bigger animal attacking a smaller animal. And a session, when I saw his mother the next time round, she said, you know, he's ever so much better. And I thought, my goodness, this works. He was better at home, but a lot of the problem of anger had been in school. So I rang his school, as I often did, and his head teacher said, it was a small school, said, yeah, he's ever so much better, isn't he? What we did, we changed who he sat next to in class. And he was with really quite a troublesome boy, and we hadn't realised how irritating they were to each other. And he was so much better. And I said, oh, thanks very much, that's interesting. Now, then I was in contact with the GP, and who I happened to know, and saw him a few weeks later. And I said, you know, I'm not quite sure why, I said, but that child you referred, really done quite well. He said, yes, you know, just about a fortnight before there was this change of behaviour, I put his mother on antidepressants. And I'm sure that must have had... So we were all omnipotent in our own particular right. The school teacher was, the general practitioner was, and I know I was. And we all have to be very careful about control, keeping our sense of omnipotence under control. Next slide, please. I think we need, these are warnings really, we need to keep in mind the things that we've really learnt over the last 50 years and not forget them, and incorporate them, if we can at all, into, if what we do is called cognitive behaviour therapy, then we need to incorporate these advances either in technique or in understanding. And there's no doubt in my mind that seeing families as a system is a helpful way of moving forward and in therapy. And I would imagine that those of you who practice cognitive behaviour therapy think it's not enough, that sometimes you have to do it, and perhaps often within a family context, and the context in which you work is of course terribly important. And attachment theory, we've learnt so much about attachment, and we need to think about the way information is normally distorted when you are attached to somebody. When you're in love with somebody, pretty well everything, all the information you get about that particular person is distorted. You wouldn't be able to remain in love with them if you didn't distort information about those with whom you're in love. And we need to incorporate into our thinking various concepts, particularly those derived from attachment studies. And I think we need to keep in mind the fact, when we are dealing with other people's children, the importance of genes. I say other people's children. If I won't do this because I'm a bit running out of time, but if you ask group of people like this, you're asked to see a child, and the child's very disturbed, and you carry some preconceptions. And one of your preconceptions is, it's the way parents have manage this particular child that is really going to be really important in what I discover. Okay? Think about your own children, those of you with more than one child, and if I ask you why they behave so differently, why they're so different in personality, you say, well, it's the way they were built. It's their sort of, it's their genes, I suppose. I didn't bring them up any differently. We seem to think of other people's children differently from the way we think of our own. And of course it's important to know how children have been brought up, but of course it's also important to remember what's been happening to them in their environment, but their genes are also important, and we need to bear in mind in our therapy the possibility of gene-environment interactions. Next, please. Then we mustn't forget what we've learned over many years. And I would claim that psychodynamic theories and mechanisms, which have of course evolved, sometimes for me less helpfully than I would have wished, but they have evolved in ways that those who are specialists in these theories think represent advances. And certainly when I used to see children and families and hear what other people had to say about them, I used to feel, and I still feel, that those with a psychodynamic approach can sometimes listen more carefully, observe more carefully, pay more attention to the relationship between the child and the therapist, or the family and the therapist. I don't like the word transference because it has for me a lot of baggage that I don't. But the relationship between the child and the therapist has been shown in a number of studies to be very important. And you ignore it at your peril. And I think those who practice CBT do well to have some psychodynamic training in order that they can be aware of the importance of their relationship with the child and family. Next, please. Next slide, please. But if you want to change behaviour, conveying understanding, psychodynamic theory, and many practices, changing behaviour, there is, as this booklet makes clear, behavioural approaches are usually those, cognitive behavioural approaches, that make most difference. And of course, people do want, parents in particular, and quite often children and young people themselves, want to change behaviourally. So we mustn't forget that that is another thing that we have learned. Next, please. Well, I don't want to talk perhaps to this one point about assessment that I would like to make. So often when people are assessed, and I'm afraid this is true sometimes of those who assess with cognitive behaviour therapy in mind, the assessment leaves the child and family feeling worse, because it's involved asking a lot of questions. And I think it's well worthwhile after the assessment finding out what the patient and family really feel like, because asking a lot of questions can be humiliating for people. Do I have another slide? Next slide, if there is one. Yes. I think I'll just stick with this and end on this point. There is a major dilemma for us. We know that those therapists who are involved in their therapy, who believe in it, who are enthusiastic about it, who know that what they're doing is right, who ignore evidence that suggests that what they're doing is wrong, get better results because they carry the families and children with them. But we also know how important it is for us to have therapeutic doubt and scepticism, and how we combine enthusiasm with our interventions while at the same time retaining doubt and scepticism about what we do is a tremendous challenge for the future. And I think it is one of the reasons why people shouldn't work entirely independently. They need to carry the enthusiasm, the individual therapist, but they need somebody else to provide a certain amount of scepticism and doubt. That is what I have found helpful myself. I just want to finish by saying I've probably talked rather too much about myself. Bad habit anyway. I'm not doing that. I'm down to meet the expert session this afternoon, and because I'm not sure if I'm going to be allowed to go to the General Assembly, but I do hope that everybody who is representing a national society will go to the General Assembly it's in the Bianca room in the Palazzo Affari to take part in discussions about the next 4 years of ESCAP. Because ESCAP is to me a terribly important organisation. I feel my ancestors all come from Eastern Europe. I've lived in Western Europe. I'm very identified with Central Europe and European ideals. And I think the future of ESCAP for my specialty is terribly important. So do take care of the society. Thank you very much indeed.
Wonderful and very erudite talk, and in particular I think it was so rich and combined real erudition and knowledge with his typical humanity and wit. So thank you very much. I'm aware that we're actually at the time boundary. perhaps we have time for one question, if anyone has an absolutely burning question. There's a lady over here. So someone with a microphone, or she actually just pointing somewhere? Hard to tell. Are you around at the coffee break? What I said.
No, after Peter Flanagan's lecture.
Okay. What I suggest to people, since we are at the time boundary between lectures, is that Professor Graham will be around after Peter Fonagy's lecture, and particularly since he isn't going to be available for Meet the Expert, if people would like to catch him then, where will you be? So that we can...
Where the coffee is.
He'll be where the coffee is. So I'd like to say again, thank you very much for a fantastic lecture.